Hello, and welcome back for another exciting and amazing episode with the Nailed It Ortho team. We are back again today. Hey guys, my name is Dr. Jay Fitz, and I also have with me.
Ooh, Dr. Wendell Cole.
There we go. So we're the dynamic duo that makes this great machine work, guys.
Oh
We
yeah.
have we have another one. I think another awesome show for you guys. This one is going to be um, just going to be great for like the junior residents and the med students who about to do those rotations and things. I say that you need to listen to this episode so that you can be
Need.
better. Yeah, absolutely, and be better prepared out there. So I'm gonna let Cody do the introduction here.
And yeah, this is definitely a great episode. One of my chief residents here, actually, Dr. Donovan Johnson, is actually doing this episode. And we're just talking about tips when you're on call, when you're by yourself, or even if your first time, how you can reduce things, how you can go about looking at things. And this is a great episode. Dr. Johnson, stand-up guy, is actually one of the reasons I actually chose this residency program where I'm at now. Is one of my chiefs. He went to Georgetown University for med school, Tulane for residency, and he matched in his top choice for fellowship over at Vail and doing sports. So yeah, I have no doubt in my mind he's already a great surgeon. He's going to have a great career ahead of him. And just without further ado, you all listen to this episode with my chief, Dr. Donovan Johnson, otherwise known as DJ.
You are now listening to Nailed It, the Orthopedic Surgery Podcast, featuring Doctors Jay Fitz and Wendell Cole.
Welcome to the podcast, Dr. Johnson, or should I say Chief Johnson, or however you want me to call you, man. Welcome to the program. Not welcome to the program. Welcome to the podcast, man. Glad to have you on and coming and speaking today, man. Hopefully we can help a lot of people out, man. So welcome.
Well, no worries. Thank you for having me, and look forward to sharing some things to the young, aspiring orthopedists and young orthopedists as well. Call me DJ. Man, Dr. Johnson stuff sounds pretty cool, but I'm just a normal guy trying to get through like everybody else, and help people in the process. So DJ is good.
All right. And say no more, DJ. About to be chief, man. How's it feel? Does it feel good?
It comes with his own battles. I put it like that. It always is good to that I'm getting closer toward the end and being out on my own and practicing surgeon. But equally so, that's nerve wracking as well, because I'm going to be by myself. I won't have a chief or a staff in front of it. It's just going to be me. So
right.
This stage is interesting because you still try to develop your craft and get better every day, and you have to do it when you're out on your own as well. But also as well, I'm going to have residents below me who look up to me, and I'm going to be the one leading the ship and leading the team, and that comes with a lot of responsibility as well. So it's the good and bad. It's good part that I'm getting close to the end, and this has been a long road, long journey. Well, equally so is we have to still hold down the fort and be able to lead by example and lead by mentorship and leadership as well. So it comes with its own pluses and minuses. So.
Awesome.
Sorry, go ahead.
Yeah, I was just saying that has to be a good feeling to know you progress through the program, and you're at that point where it is time to go out on your own. But on that subject, so we always start off with a few questions. So that's good. We're already getting into it. So what specialty did you choose, and why did you choose it?
Great question. Actually, it was a struggle for me to actually pick a specialty. I always knew I wanted to do orthopedics, in college, and always wanted to do sports medicine when I started residency. But, going through residency and spending these, 3.5, 4 years here now, you get exposed to so much in such a little bit of time. You do trauma, you do spine, you do shoulder and elbow, you do sports. And, I kind of found myself kind of liking everything. And what made it tough for me is to find a field which I can, see a diverse patient group, which is young and old and, athlete versus, the pops that go out and play golf every now and then, to, taking care of high energy trauma to athletes and all those things. And, I settled on sports medicine because it's probably the more diverse one of all of them. It's more of how can I put it, like I won't say private practice skill, but, you can kind of pick and choose and see what you want in that field. Trauma, is whatever comes through the door. And the fields I kind of decided to pick between was like trauma versus sports. I was on a spine kick for a while, but I think sports I settled home in that field based on those things. So actively right now, I'm applying to sports fellowships, and it's been an interesting process. A little bit different for residency. It's not as intense, and so it's good to be exposed to different places, different programs. They all kind of do stuff similarly, but they all do stuff different. And so that's kind of what I'm gonna dedicate my life to initially is sports medicine. So
I like it. Okay, yeah, I can see. I definitely understand. It has to be a pretty tough choice to finally have to narrow it down and pick whatever you're going to go into for the long term. So yeah, I definitely can see it taking some time to kind of narrow that down. But on that same type of train of thought, I guess, what would you say is your favorite case to do? Whether it's sports or whether it's trauma, whatever it might be, which one do you think?
Well, it depends on kind of where you are. I mean, I'm sure like as an intern in the PGY2, just getting in an operating room is a good time, and get your hands dirty and do some cases. Early on, I really enjoyed the bread and butter trauma, like, femur fracture coming in and putting a nail down, or tibia fracture, someone coming in, you put in an intramedullary device. You can actually get people up and walking the same day. So that stuff is pretty cool, Now, as a more senior resident, you've done enough of those, you've done a lot of those. So we are at the point where, more complex stuff are pretty interesting. So, like multi-ligament knee surgery to me is pretty cool, in which we can reconstruct multiple ligaments from an injury and, again, have someone back to hopefully doing their normal activities and given a given time that they have to rehab. So those are pretty good cases. I like complex shoulder stuff, like shoulder replacement, revision surgery. I like the rotator cuff surgeries. Even in other fields, I like, total knee replacement, total hip replacements, and also some of the bread and butter, like spine cases, like a single or two-level cervical fusion or, lumbar discectomy and those things. So it's kind of, every field in terms of orthopedics is different, and, the cases are different as well. But for me, I like the little tedious ones that take your time to get through them, and always got to be perfect. You know what I mean? Or try to be perfect. So.
Right. I totally understand that. Totally get it. And, the last question here we want to ask you, this last question here. So is there any, you're coming upon your chief year, is there any advice that you would give yourself as an intern, kind of looking back at it now?
It's a great question, Dr. Cole. Looking back, I guess, you always can do more. You always can read more. And you always can, I guess, educate yourself on your craft. And again, we're going to be doing this for our long lives. And, you always can get better at it. So looking back, I think if I can talk to young DJ, and he was an intern running around not knowing what to do, is to, study more. Even though you study a lot, you always can do a little bit more. You always can take 15 minutes in the morning or maybe 30 more minutes at night just to read up on stuff, only because, things in orthopedic change. Like I kind of tell everyone, if you're doing what was in the literature 10, 15 years ago, that may not be the standard of care now, so you always have to be on top of everything and kind of know what's out there. I mean, because, it's all said and done, you got to do what's best for your patients, and if it's doing the most up-to-date stuff or knowing the most up-to-date stuff, to me, that would give you the best, I guess, ammunition to tell your patient, like, hey, this is kind of what's the most up and current thing about what's going on with you. And these are the choices you have. And, help patients kind of formulate the decision that's going to be best for them. So.
Yeah, man, I think that's great. And I think that's a great answer. So I guess we'll go ahead and transition and kind of get into the topic of the day, which is kind of like tips and tricks for, interns or other residents that are coming to take primary call, things that can help you out, make it a little bit quicker when you're doing reductions or, just the little things that can make, your
right.
call life easier. And I know every program's a little bit different, I guess on like the structure, the amount of kind of calls that they take. So I guess kind of how would you, I guess you can give a general background of how our residency program works, just to give people like a little intro onto like how call is, and then, I guess we can kind of go from there.
Okay. Yeah, I got some notes taken now about call in general. Call is going to always be one of your responsibilities, even as a medical student, a junior resident, a senior resident, or even, a staff surgeon, you're on your own. You're going to take call. That's just part of the job. It is a rigorous time, but, you learn a lot. And I think that's where a lot of, junior residents learn their craft is doing call. There's different types of calls. Number one, let's start off with the basics. You got primary call, you got secondary call. Primary call, that's the person who's, the front line. That's the second year resident or intern during the day. But the third year resident, who's the one carrying the pager. They're the ones that have been called for the consults. They see the consults. They make the plan for the patient. And then the secondary call is the backup call person, which is likely most cases is a chief resident, someone who the primary call person sign out meaning telling the senior resident, hey, I got a X patient with this type of injury. I think this is the plan, and they're the one that kind of solidified and say, hey, that's a good plan. And so that's the two type of calls, kind of what we have here at Tulane. I think that's kind of mostly where at other places as well. Primary call is usually front loaded, meaning like your interns, second years, again, and third years of the residents is usually people who actually take primary call, and then the backup person is more the chief. In our program, we have a home call system. And please stop me at any point in time if you have questions about any other. You got an in-house call, you got home call. In-house call is, what larger programs have, in which you have the resources in terms of the resident number, in which you can keep someone in-house during the nighttime, and that person is take the call. And that's usually broken up in 2-3 month blocks, and you share it between, the residents in your class. They usually take care of all the consults in the nighttime, and then in the morning time they have, fracture conference. They sign everything out to the group that's going to come in during the day. A home call system is kind of what we have down here, in which you not necessarily have to stay in-house, but in return, you have to come in if there's consults and stuff that needs to be seen or cases that needs to be done. On the downside of home call, as you guys know, is, you don't have dedicated post-call time afterwards. Given that, you have time to go home during the night time and rest.
Supposedly.
So sometimes, supposedly. Most times you do, sometimes you don't. That's just kind of how it is. But you always tell everybody, yes. And I didn't work no more than 24 hours, obviously.
Of course, right.
But with the call, right. But with the call system, especially at nighttime, at this home call or even backup, and I guess one of the topics we're going to talk about is you may be the solo guy. For me, we only had 2 interns below our class, unfortunately. And one of the interns was always on gen surgery, and then the other intern was on orthopedic rotation. So share between my other 2 co-residents, 2/3 of the time you would have backup person with you. You would not have a backup person with you. 1/3 of the time you would have an intern. So you have to learn how to do things by yourself. And that's part of it. Even when you come out of residency and your staff somewhere, you may not have a resident who's going to see stuff, and it just may be you. So
were you guys doing call 8 times a month, like how we do it now still, when it was just you 2?
Right. It depends on how many residents in your class. I mean, if you have more, obviously, then you have less call days. And then if you have fewer residents, you probably have more. For us, yes, it would be, general 8 call days. We have a unique system down here where, we have another residency program in town in which we split the trauma call with. So every other day we're on trauma call at the trauma hospital, but we're on call at the hospital that, where our residency program is out of every day. And so you split those call shifts up from the 15 call shifts, which is half of them, 15 to 16 a month between the primary call people, which equates to about 5 or 6, give or take. And then the rest of the nights is going to be just on call, just at our hospital. If that makes sense. And so we were about 8 a month for the whole year.
Okay. Yeah. So I know at our program, so I don't have a whole lot to add to this, just because as interns we don't take call. We don't take any call during our first year.
Lucky.
Yeah.
So you.
Yeah.
You don't take any night call, correct?
No night call, right? Now we take everything during the day. Like our seniors they don't touch anything as far as the only thing my seniors doing are OR. That's the only thing they're doing, either in clinic or in the OR. Anything else that's happening, the intern takes care of that. But at 6 o'clock we sign out, and either the second, third, or fourth. I think it's really just second and third, not so much fourth year. Some fourth year still doing some call, but not night call, but not much. And we sign out to them, and they handle it from the nighttime. So that's kind of how our program is set up. And I think they tend to take about somewhere between 5 and 6 call shifts a month, something like that. Because we have like 5 per class. So once you spread it out, it ends up being about 5 or 6 per class. I mean, per month.
Right.
But on that same tip, I know you say just kind of going into being that solo guy at night. Even though for our program, everyone says first year is the worst year out of all of them, just because how things are kind of set up. But they do say the biggest change is that second year, when now you're by yourself and you have to make those decisions. Like, should this patient stay? Can this be something done outpatient? Is this emergency? Those different things. So I try to keep that in mind even today, because we pretty much see our consult solo. We're on our own when it comes to our consults. So I try to kind of think to myself, like, all right, if this was my patient, or if I was by myself, what would I do with this guy? Would I let it? Does this need surgery right now? Does this need surgery tomorrow? Could this be done outpatient? Just to kind of prepare myself for next year when I really will have to make those decisions.
Right, and I think that's the tough part with the transition from being an intern. Even though they call yourself an intern these days, you still do a lot of orthopedics with the new changes in which you can do 6 months orthopedics. To be in the PGY 2, which is your first year of your orthopedic residency, being on call by yourself is very stressful. And I think, just being a more senior person now, and having junior residents who actually call me and running consults, I think the biggest thing they struggle with initially is confidence, right? Which is seeing a patient, trying to be efficient and self-sufficient, and in terms of seeing the patient, seeing x-rays, working everything up, formulated plan, getting all the materials ready that you would need for when you call your chief, pretty much everything will be done. And I think the confidence itself, it takes time. I mean, it takes time to learn the things, but it comes with the reps. You know what I mean? Like if you have enough reps and you see things of, say, one pathology multiple times, you should at that point in time kind of know what to do with it. And so being, by yourself, is nerve wracking, but it's everybody has done it and everybody will get through it. I think the best way that you can initially at this point in time as an intern, as a med student, or, first year resident, second year resident, is to observe those people who are ahead of you and learn and see what they do and ask questions as well, and to kind of see, hey, why did you do this? Or why did you call this person? Or why did you put this splint this way? And those little small things will actually kind of help you out through the process. And I got a little bit more details in terms of specifics we can talk about a little bit later. Yeah. But being solo is tough. I mean, it's just you know what I mean? But even though you're the solo resident in a hospital in orthopedics, you still probably know more orthopedics than anybody else is in the hospital. So trust that you know your craft and you're going to do the best for people. But again, that all comes with time. All right. It comes with reps as well.
Yeah. And I think that's a perfect segue to go ahead and transition into like actual tips and tricks. I think a good way to kind of go about this is we can kind of speak about generally first and then kind of go into like ways to handle some upper extremity things, talk about like casting, tips here and there.
Okay.
Go to some lower extremity things. One of the first questions I had, are there any times where you have something come in that you should just call a chief as soon as possible, like ASAP? You see this and you're like, I need to go ahead and call a chief and let him know about it, without wasting time. Like, are there any of those situations where it's like, hey, you need to go ahead and call your chief right now?
Right. I guess that's a great question. But I think mostly it depends on the type of program you have. Some programs, some chiefs want to know about everything. Depends on who you're on with. When the stuff hit the door, so they kind of have a plan in place or know what to expect. Some places, they want you to see the patient, make sure all the x-rays are done, get a plan in place before you call anybody. I think, being there here in New Orleans, that's kind of the latter is kind of where we stand in terms of how we want to do things and process like consults. So at least for here is like when something comes in and hit the door, usually we want to make sure folks have eyes on it so they know what's going on. I mean, how many times, have you got a page and say, hey, we got this guy here had a laceration on the leg. We think they have an open fracture or whatever. And they call you and then, you go off and you call everyone there, hey, we got an open fracture downstairs. But once you get the x-rays, there's not even a fracture. So you always want to make sure you at least lay eyes on and know what's going on and make sure that the workup and the plan is like in place, at least before you start to make phone calls. Because you want to make sure you have everything done. Again, you don't want to be the guy that's, calling everybody when nothing is there because, it's more just, at least for the residency standpoint, the residents, I mean, I wouldn't personally care, but some of your staff may not want to know about any consult unless they are coming in to do surgery, if that makes sense. And then they probably prefer to be signed out the next morning with stuff.
Yep, I totally understand it.
And along with that, just to mention it because it's something else that I hate. Not only like the laceration and you look and it's not even fracture, or they come in as a trauma and they, everybody talking about this obvious deformity. They call it deformity. I'm like, and then they get the X-ray, and I even look, and I come down and look, and I'm like, I don't really see it, but okay. And then
right, and I mean, and that comes with the point I just made. Even though you may be the only person in a hospital that's doing orthopedics at night, you still know a lot more than some of the other stuff because this is kind of what you do and that's what you see. And so that's my recommendation. Always lay eyes on everything before you start making phone calls because, when it's all said and done, it's your responsibility anyway if you get a consult to see the consult and to know what's going on with that consult. So at some point in time, you got to go in and say it anyway, right?
Exactly.
Absolutely. So I guess we can go ahead and get into it. So what are some of the tips of the trade, say for like maybe we'll say upper extremity injuries that you would have as far as being the solo person going to see these consults as far as casting versus splinting and different things like that?
Okay. Yeah. So I'm going to start from the top down, let's say with shoulder and elbow and then some forearm and then wrist stuff.
Perfect.
Yeah. So, when you're on call and the consult list start to fill up and say you go from having 2 consults to 3 to 5 to 6 to 7 or more, and you still seeing the first or second one, you will learn how to quickly learn how to be more efficient and how to get through your consult list in a timely fashion because, you can either take 2 hours to see everyone or you can take 7 hours to see everyone. So with shoulders, I mean, probably the more common thing that you would see in, orthopedics and in a trauma bay in which you would get called for, at least for our hospital, is either going to be fractures or dislocation. That's pretty much most things you're going to see versus or a septic shoulder and those things. So for, we could talk about shoulder reduction, so that's probably the one that's going to take the most innovation for you, I guess, in terms of having to do something in the trauma bay. And so shoulder reductions itself can be tough. So what I recommend for any medical student, intern, junior resident, if you get a consult about a shoulder that's dislocated, the first question you'd ask is what x-rays has been done, and then make sure that all the appropriate x-rays have been done. So you have to personally look at the x-rays itself. Some of them just get an AP view or maybe a scap wide and call you for a shoulder dislocation. To the untrained eye, maybe look out, but it may not be. So, I'd recommend everyone to make sure that the appropriate films are done, which are APs, axillaries, scap-wide views. If, patient refuses to use the arm, what's another type of x-ray that you can get that, called minimum manipulation of the extremity. It's a Velcro deal. And, one of the hospitals we work at, the x-ray technicians always push back about touching extremities with fractures or dislocations. So we always can tell them, hey, just get a Velcro view if you can't manipulate the arm to get axillary.
Right.
And and also get full length films of the extremity that's involved in terms of the joint above and joint below. So, always get your humeral films and elbow films. And then if you get those x-rays and the shoulder is out, that's kind of what you're going to go with. Usually some ED departments take care of it. Some of them don't. I mean, that's kind of how it is. I know for our philosophy down here is if they call us for a shoulder dislocation, then you calling us to do it. Sometimes you go in and like, well, can we give it a try and have you guys stand by just in case you need to point you through the direction? No, you called us to do this. We're going to do this shoulder dislocation, right? And so observe your senior resident and see how they set the room up in terms of if they do a shoulder dislocation or reduction. It's kind of two ways I do it. I can do a shoulder dislocation when it's just me, and I can do one if I have like an intern or second year to show them kind of how to do it if you have another set of hands. So you will be the team member in the ED directing everyone. It's going to be like you're the pilot that's flying the plane. Whatever you say, that's what they should do. All right. And always ask questions like to your senior resident, why you do this? Why you move the bed this way? Why you do this thing? So I come in, the patient got a shoulder dislocation, which the ED can't reduce. First thing that you're going to have to think about is if I'm going to do it with a person there and show them how to do it, if you have two hands to help out, I start moving everything out of the way. I move the bed to the side of the room in which we can work give us more space to work in terms of like, say, if it's the right shoulder, move the bed to the left side of the room so we can stand on the right side. You have to think about what medications you're going to have to give, to sedate them, not sedate them. You're going to do intra-articular block, or you're going to give them PO medications. And so tips with that is if you're doing it with someone else, the standard method, what we used to call back in the day, or in my med school, which was the Captain Morgan, whatever you call it, when you put somebody pulling a sheet, the patient one way, and somebody else is pulling another way. That's good. That's cool. I normally sedate the patient for that, so it doesn't seem as traumatic to them, or giving them some medication so they won't remember a lot of it, even though it's not gory. It's just multiple big men pulling on you to try to get your shoulder reduced.
Yeah, absolutely.
But there are a couple of methods that I use myself to help with like close reductions when I'm by myself. Two methods, you want to look it up. There are two articles that's written about them. One of them is called the Fares method, Fares. It's if you by yourself. I believe it's a recent paper back in August of 2018 out of Lebanon that described this method, in which they don't even give people medication to do it. It's more of just you walking the patient through the steps of reducing the shoulder. Say if the left shoulder, they land prone, you land flat. You take their hand, you extend the elbow all the way, and then you point their hand neutrally. All right. So while you're giving handshakes, you're talking to them like, hey, it's going to be okay. I know this is a bad traumatic event for you, but we're going to get this shoulder in. You passively abducting the shoulder all the way up to about 90 degrees. You do some vertical oscillations to kind of loosen them up a little bit and hopefully try to unhinge it. And then usually while you're pulling traction and abducting it with external rotation on the shoulder with the vertical oscillation, you should feel it self-reduce. And then once the self-reduces anywhere between 90 to about 120 degrees abduction, you internally rotate and you just bring the arm back to the side. The other method I use is in which I don't have to do medication. This is the one I use on the sideline. I lay a kid flat up prone on a bench. If the involved shoulder adducted past the side, in which pretty much the elbow was like almost midline, I externally rotate the upper extremity, and I usually unhinge it. If it's an anterior and inferior dislocation, I usually unhinge it, and then as I bring it back to like kind of that same motion, the abduction, internal rotation, that usually reduces as well. So those kind of two methods that you can use that doesn't require medication. Patient usually tolerate it well, and you can actually get it reduced and be fine. But the caveat is that usually that dislocation mostly is anterior inferior. So if you have a superior dislocation or inferior dislocation, you can manipulate the humeral head to make it a bend anterior location. Then you can use that technique to do it.
Right.
Posterior dislocation are completely different. Those are out of the scope of this one. If you get one of those, usually you just kind of pull traction with that. and that kind of reduces it.
And you said the Ferris one. I think, is that like the fast, reliable, and safe? I think I read about that. And you said that one, you hold their wrist and gentle traction, and you kind of oscillate the outstretched arm while abducting.
Correct. So usually I extend the elbow kind of right at the maybe 10 degrees of abduction from the side, having land flat. Wrist is at neutral, meaning kind of thumb is kind of pointing like straight, not straight up in the air, but neutral for the neutral position. And as you pull on traction, you're taking them to abduction. And once you get around about 80, 90 degrees, you start doing like vertical oscillations, like almost like a handshake. You start shaking the arm. And then once you start to get roughly about 80, 90 degrees, you externally rotate the wrist, which is usually unhinges if it's stuck, say if it has an impacted heel fax, whatever, that unhinges the humeral head against the glenoid. And as you externally rotating it, still pulling traction, and then occasionally doing your vertical oscillation, you should feel the shoulder reduce at that point. Sometimes you may have to abduct it past 90 degrees from when they land prone. And then once it abducts, that's when you externally rotate it, bring them back to the side, and then whatever your facility or your residency program, you put them at abduction pillow swings. We make our pillow swings sometimes. And so that's a really good method to use. It works. I haven't had one not to work.
Okay, I'm about to look that one up. I've never seen that one, but I've also haven't gotten a lot of experience, say, of these injuries happening with, like you say, pretty much in non-traumatic, or I guess you could say, I haven't seen like with sports injuries and different things like that. Like, what would you do on the sideline for this type of thing? And so that's good to know. I'm gonna have to look that up and kind of see how that works.
Now, if you are on a football field and shoulder, kid dislocated shoulder, and it's obvious, they hold an arm in an abnormal position that doesn't look right. I usually try to calm everything down. I take the patient or the player off the field, I take them in the locker room. That's when I reduces it. I don't want to do it on the field, on the sideline. Everybody's looking at you. The parents are crying and those things. Calm the situation down, move the kid in the locker room, get the shoulder back in, and then kind of go from there and make sure they come in and follow up afterwards. I have had shoulders not reduce, not using that method, but it takes the right patient. It just takes a patient who's not hysterical, who you can talk through while you're doing the process. But I've had some in which you have to sedate them and get them in, and I have some that you couldn't get in. And so the irreducible shoulder, if you guys want to jump in that, we can. You gave it 2 attempts and then reduce. So
let's do it.
I always tell everybody, especially junior resident, to give it 2 attempts before calling someone. All right.
Okay.
But in the interim, if you calling someone, you always need to do a few things if you can't get a shoulder reduced. The first thing you should do is obviously is go back and look at the x-rays again to make sure that the humeral head, say, if it's not impacted in which you can't unhinge it. Is there another fracture in which you're pulling through, and that's the reason why it can't reduce? And then, or maybe the humeral head you thought was anterior is now, inferior, or is it inferior now is like anterior superiorly. There's always something that's there that's you are not realizing that's keeping you from getting the shoulder in. And so if you try twice without any medication, sedate the patient, ask for propofol. I know everyone is probably scared of it, but propofol for me is, with the, the right, team that's monitoring everything, that's the one that really gets people sleepy enough in which you can get them relaxed. So you really can give the shoulder a good try to get it in. All right. And then I say try it again at that point. And then at that point in time, you can't get it reduced, given that's not a fracture, given that's not all these other things. That's when you call your chief and get them involved. So.
Absolutely. I like that. I think that's a good way to do it. I always try to give it at least 2 good goes at it. Also, this next one is something I haven't had a whole lot of experience in. What are some of your tips for, say, the elbow dislocations when you have to reduce that?
So elbows are a little bit easier to me with compared to shoulders. Elbows, obviously, it's the same process, the same steps that you got to go through. Someone comes in with obvious, and these are usually you see obvious deformities. So the ED call, you say they got an obvious deformity in the elbow, you already know it's going to be a dislocation.
Right.
And so usually the big thing to look for on x-rays is make sure you always get the joint above or below, make sure you're not missing anything. So get elbow all the way down to wrist. They are mostly commonly associated with fractures, if it's fractures involving the ulna or the radial head. So some of those things will kind of help direct you what you do. So for elbows, you need to, focus on what direction is the dislocation. If it's medial, if it's lateral, if it's posterior. Sometimes it can be posterior medial, posterior lateral. And to reduce those, always tell every junior resident. Elbow dislocations are fairly easier to reduce compared to other joints, but make sure you always have C-arm or mini-C in the room to take live x-rays, only because you always want to make sure that the joint is concentric on the lateral view when it gets reduced. But the most important thing is while you're reducing it is to make sure you see what angles in terms of degrees of rotation that the elbow is stable. All right. Usually with that one is, you just put one hand, I flex the elbow up to 90, put one hand on the humerus, and then I just literally pull traction. In most cases, that reduces. Sometimes they can be unstable in flexion, they can be unstable in extension. So that's what the fluoroscopy helps out to see when does the joint come out, and then you just splint the patient in a stable position. All right. Always range the elbow and document the range of motions, and also document what degrees that it pops out. In terms of setting everything up, usually most people tolerate this pretty well with just an intra-articular block or sedation if needed, only because, you're going to be doing so much and taking those x-rays as well.
And so really quick, when you said you flex to about 90 degrees when you're about before you pull traction.
Mm-hmm.
Now, I remember I was reading somewhere, maybe I got it wrong, but it was like if you extend, well, I guess if it was already flexed, but you like extend to allow like the coronoid to like clear the coronoid from the acromion, from the distal part of the humerus. But yours is, you typically mostly start at 45, pull this kind of axial traction, and then you test the range of motion and you confirm with fluoroscopy.
Well, right. Sorry. So, great question. I should have been more clear. I start traction when I start flexing probably like 10 degrees, and then I would bend it up to about 90. And sometimes most cases you reduce it before you get up to 90 degrees. So you're right. So you want to pull axial traction before you get up 90 degrees to clear it. But usually once you get up to 90 degrees, it should be reduced at that point.
Okay. Yeah, I haven't seen a whole lot of elbow dislocations, and I think there's probably been two that has come around since I've been, when I'm actually on the ortho service. For whatever reason, by the time I get to the ED, someone's already reduced it. Like the other intern might have already reduced it, or either it came in at night and I wasn't there. So I haven't actually gotten to see this maneuver yet, but it is something I'm really hoping to get some experience with before next year. So when it comes in, I'm not looking too lost. So it's actually good to hear your technique for sure.
Yeah. So, and again, always pay close attention with your senior residents and how they do things, because every center, every place do things a little bit different. All right. The most important thing with elbow dislocation is I'm going to ask you this one, Cody. After you get everything reduced, you need to do what?
You mean as far as getting like post-op imaging?
Get post-op imaging, but before you get the images, they need right. And you get a range of motion for sure, but you always got to put them in a splint.
In a splint.
All right. Because they easily can pop out. They start waking up and they move it, or they try to, extend or flex, and it pops right back out again. And always make sure, like if the ED call you, hey, we had this guy to come in with a elbow dislocation. We reduced it before we call you guys. What do you guys want to follow up? Or when do you want to follow up? Next question you should ask is, how's the x-rays? Is it reduced? And the second question is, did you guys put them in a splint already? There's been multiple times, or sometimes where they say, no, well, we haven't splinted them yet. And then they go back and get repeat x-rays and they're already out again. So splint before the patient is waking up, and splint them in an unstable position in which it's not going to shift out.
Now I've read some things. Go ahead. Now I was going to say, I've read some things where some people will put them in like a hinged elbow brace after they reduce it. Have you seen that used as much, or do you just typically the splint?
Correct. If it's like just a simple elbow dislocation without a fracture, sometimes you can just put them right into a hinge elbow brace and to get them moving. Because the longer you split in the stiff of the elbow, it's going to get. But traditionally for our institution, we split first, and then have them and see them within a week, and then that's when we transition them to the elbow brace, mostly for comfort. Because if it's going to hurt, then they likely won't move it. And so we put them in a splint to keep them from moving it. All right. In the tough ones in which you splint and then you check X-rays and they already, pop out again or dislocate or sublux because it's still unstable. Sometimes you have to put those in a long arm cast that's a little bit more stable than just a splint. All right. So that's another little pointer for you.
Nice.
Okay. Yeah, that's gold. I think all those tips are pretty gold to have. But I'm glad you got Cody straight on what to do there too.
He knows. Trust me, he knows. They don't call it us. Like he knows what the best thing, because the biggest thing is you want to just make sure these are the questions that your chiefs and staff is going to ask the next morning. What was the range of motion? When did it pop out? How did you splint them? Let me see your post-out splint or post-reduction film. Sorry. So these are going to be the things that you have to think about, and part of how I tackle is like when I saw consults, what all that I need to see and do to keep people from asking questions. All right. And so do as much as you can. And there's nothing wrong with doing more than you need to, just to make sure that you covered everything.
Absolutely. This next one here is probably something, it's probably one of the most common, reductions that we have to do in the ED. What are some of your techniques for the distal radius fractures that you see in the ED?
Yeah, I got distal radius reductions. That's my number one upper extremity code, I guess, when we log out cases. You're going to get a lot of them. They're going to come with time. I still remember the first one I did. It probably took me about an hour and 10 minutes to reduce and cast. I got them doing them now I do them every 10 to 15 minutes. So that's what comes with time. Distal radius, that's going to be your arch nemesis as an intern, because when that comes in, it's going to take you a while to do it. I teach everyone to do these reductions. That's like if you're doing them by yourself. Tulane is in New Orleans where we train. It's a place where close reduction for some of our trauma staff, they want you always to attempt that first, because when you take your board exams, they're not going to want to see you fix all of them. They want to see that you attempt close reduction. So reducing distal radius fracture is going to be part of your repertoire of techniques that you're going to have to at least perfect as a resident. And so the way I do them is I do, number one, pain control. I always do hematoma block, which I introduce numbing medication to the fracture site itself. I do a mix of lidocaine and marcaine. Lidocaine, as you know, it works well, but they're only going to give them 2-3 hours pain relief. The marcaine is what's going to give them pain relief at the fracture site for several hours. So you can either reduce and cast, or you can reduce and split. And the way I reduce them is I use the finger traps or a Curlex roll, which I just hang just for your standard Colles fracture. I just hang them by the thumb, get a little older deviation of some traction. I put some weight around the arm. You can use the bean bags or the poor man's way of what we do. We take some stockinette. We put 2 or 4 bottles of the 1 liter salines. So it's about 3-4 feet long, and we put 2 on each side, and we just hang around the arm, and that applies some traction, general traction. And then you just hang them up. You hang them up. Sometimes it takes 10 minutes. Sometimes it takes 11 minutes to get the fracture almost, mostly reduced. All right. And then once you do that, then you just do your technique, and then you'd be done with it. But the good thing is, if you have 2 or 3 distal radius that's hanging around, once you hang one patient up, give them 10 minutes or 12 minutes to fully relax the point that the fracture is almost reduced, you can go do hematoma blocks and hang the rest of them as well. So it's going to be like a little, like a simulator line. And
right.
We cast ours, and so we can either put them in a splint or put them in a long-arm cast. Cast makes it a little bit more rigid. You just got to make sure you don't make it too tight. And the way I do it in 2 stages. I do the upper part first, which is like from the armpit to a little bit distal to the elbow. I roll that out with plaster. I mode it, and then once that dries, I put the weight back on so I can stretch them out a little bit more. And then I do the distal portion, in which I can do my reduction removal maneuver after I roll it. And usually that holds pretty well once you get done. You can either close reduce or you can splint. Splint's a little bit easier. Just put them in a sugar tone after you do it. And I still use the same method, which is hanging. I hang by the thumb if it's collies, or if it's a volar shear. Usually I just hang it by the middle ring finger, and that usually pulls a little bit of traction. I just do a gentle mole and extension to keep it there. So with this technique, you can do it by yourself. Obviously, if you have intern someone with you, that'd be great, because someone can hold traction on the arm while you pull it. But it's a little bit more gentler for the patient to have them hanging versus you have someone just manipulating the arm and they feeling the crunch feeling and all those things. That's the stuff that people's going to remember, patients going to remember. So,
yeah. And you say that you before you even do the reduction, you go ahead and cast like from mid arm to mid forearm, and then you do the reduction and finish the cast. Is that right?
Well, yes, I cast from I do the proximal portion of it. I cast from the armpit to the elbow. Some people does the opposite, in which they cast from the MCPs probably to, just distal to the elbow. They do that first, then get the mold, and then finish it. The only reason I like doing the top part is I can do the top part and have that dry a little bit. Then I can put the weight back on and have the weight assist me with the reduction, so I don't have to pull too much traction. That makes sense, because I'm doing it as I'm doing it by myself.
Right.
So I let the weight from the weights that I put on from the weight or the sandbags to distract the fracture a little bit more. And then I do my roll, and then I do the mold, because if you take the weight off, fracture is just going to displace again. Mm-hmm. Right. And so I wanted to put the weight back on to distract it and keep it reasonably, close to being where it is. And I just do the mold once I get the plaster rolled on for the distal segment of it.
Right.
So a couple questions on that. And I know it's going to be different on which program you're at, but what's the thought process behind going immediately to the cast versus sugar tongue first? And also, are you guys using a C-arm when you guys do this? Because also, I was just kind of thinking about it, like, what if, it's not as well reduced as you thought, but you already have it in a cast? So how that kind of looks?
Right. So that's a phenomenal point, Seth. So casting versus splinting is institutional. So our senior trauma surgeons always want us to try to cast if we can, because you try to not treat most of them if you can. Obviously, there's some that you can't. A sugar tone, I will use a sugar tone if the patient is really swollen, or some of my other staff who's on call and say just place in a sugar tone versus casting it. You're still going to have to reduce it. C-arm itself is a tool that I recommend. I don't care if you reducing a finger to reducing a distal radius to an ankle, whatever, or tibial shaft fracture. C-arm is going to be your best friend as a junior resident, because you don't know how it feels yet to have a decent reduction. Okay. Once I was a PGY 3 or now a 4, I don't use a C-arm when I do the reduction, because I just can look at the fracture and say, this is how it's going to be reduced, and I just do it. But you're right. But having a C-arm on board can help you with, either over reducing it or under reducing it in terms of, pushing the piece to volar versus not enough reduction. That's going to help you with that, because the worst part is you was lazy and you didn't use the arm, and your right fits, and you do a distal radius reduction, you get x-rays, and the reduction is nowhere near where it should be, and you got to take it off and you got to do everything else again. Right. So C-arm does help with that. All right. So that's a great question.
Absolutely. I at our program, like I really don't even know where the C-arm is at our program. We don't use it. If we had to have it, I wouldn't even know where to start to go and get it from. So at the Children's Hospital, we use the C-arm. At the Children's Hospital, they're a whole lot more, for good reason, with the open physis and everything. There's a whole lot more going on with their reductions, and they want us to be more anatomic with our reduction, so they have it right there. And, every reduction has a C-arm in the room, and it's very helpful. It's actually great. But, for our adults and the regular, like our general hospital, don't have a C-arm at all. And with that being said, there's been plenty of times I had to take my splint down and I had to redo this reduction because, I mean, it still needs just a little bit more push over to get the volar tip right or something like that. Reduction just not quite perfect. This is it could be one that could possibly be non-operative if we get it right. So that is it's a bit of a downside. It's good and bad to it, but you know.
Right, and there's ways to get around it. I mean, if you guys have digital X-ray, then I will have the X-ray technician at bedside too, if they are willing to do it, to take a couple pictures to make sure that it looks great before you commit to it. But you're right. The C-arm does assist with a lot of that. And for kids, you know, obviously you want them to be, you know, as perfect as possible. But also with kids is, you know, usually they are sedating kids for you to do it. You don't want to sedate twice. Kids are less tolerable with some of the manipulation stuff than an adult. And pulling out a big needle to try to do a hematoma block on a kid, you know, they're going to freak out. So that's probably the reason why they want it there. So to make sure that you get it right the first time, you don't have to traumatize the kid and do it multiple times. Or give them more sedation that they shouldn't need.
And then Jay, isn't the people that wrote the recent paper talking about the utility and the effectiveness of the C-arm and distal radius fractures, aren't those your chiefs that wrote that paper?
Yeah, those are my current chiefs. I think they might have been 3s and 4s at the time when they wrote that paper, but they are now my chief. Yeah.
Oh man, they tell you.
I'm not familiar with what did the paper say that is. It's not. You shouldn't use it. What was recommendation?
Yeah, the paper, it was just looking at the effectiveness of using a C-arm versus not using a C-arm in distal radius fractures, and they didn't see any like major difference as far as using a C-arm and not using a C-arm as far as adult distal radius fractures were concerned. That was kind of the conclusion.
And who was doing the reductions? Was it like the junior residents or more senior residents or staff?
Yeah, it was. I think it was all the residents. So it was the junior residents, and I think they had some 3s and 4s in there. I don't know. I don't remember how many 5s that were doing the reductions, but I know there were at least 3s, and of course, you know, the junior residents doing the reductions. They put in there like the perceived difficulty of the reduction. You know, they noted all that stuff in there.
Okay. Yeah, it's an interesting paper. I'm gonna check it out for sure. You know, I'm still gonna recommend everybody, especially who's just starting off, to take a few pictures if you can, just to make sure that your techniques, that's what you're doing, is actually, you know, is effective with the reduction. Because you don't know which way to pull, how much volar tip that you need to be pushing. Is your mole at the right location? Those things like that. That all kind of helps with you kind of getting the feel for it. And then you're right. You know, the more senior you get, once you have that feel down, then I think the utility of using a C-arm is probably a lot less than it is early on. But early on, it's all about you're now starting to make your craft. And the only way you can make it is you have to understand, you know, what maneuvers you need to do to reduce any particular fracture.
Right.
Absolutely.
That's and so we just have a couple. Go ahead, Jay.
Oh yeah, I was just going to say, just to kind of close out on the upper extremity, I wanted to also see if you can give us whatever tips you may have on INDs of, say, the finger, or you know, say at our hospital we have a lot of IV drug users, so we get a lot of abscesses in the forearm and different things like that. Any tips you have for that, and also like finger amputations, just like how you kind of go about that, being efficient as possible when you're the solo guy.
Yeah, those things, man. I'm telling you, hand call at the trauma centers are brutal nationwide. You got to do it, and I mean that's the only way you're gonna learn how to take care of some of this stuff. And finger pus, that's what we call it, and hand pus, and injuries and stuff that requires amputation. I mean, it's tough stuff. I mean, you're doing it in an ED setting in which, you know, it's not a formal sterile operating room in which you can control everything. You know, you got to be safe as possible to protect yourself. So eyewear, gowns, all those things. That's what I kind of recommend to start off with. Finger pus is finger pus. I mean, if you see a pocket of pus, cut it, drain it, leave it open, let it drain, pack it, those things. I mean, those are kind of the steps to do it. The only thing I can kind of recommend with is, like, you know, making sure someone have an adequate analgesia for it. Usually, unfortunately, I mean, folks who, you know, use some reason why a lot of them don't like needles when somebody else stick them, and so you have to make sure that they're comfortable as possible, and make sure their pain control is adequate as well, because usually they have a little bit more tolerance than someone who's naive in terms of pain control. So I usually try to get it a little bit more in terms of medication to make sure that they are tolerable for it. I mean, it's a horrible experience no matter who they are. It can be a fisherman who got stuck by a catfish who I've seen before, or, IV drug user. I mean, it's a traumatic experience for somebody to perform a IND. IND is, someone who doesn't know who's listening, is, you numb up the digit, you take a scalpel or blade, you cut the skin down to where the infection is, and you have to sometimes use other instruments to spread the tissue to kind of get all of the pus out. In terms of the infection, in order for your body, the antibodies to work. Antibiotics doesn't penetrate abscesses because there's not a blood flow inside of them. So the best way to get rid of abscess, everybody knows, is the gold standard way is actually to remove it. And so in order to remove it, especially for hands, you can do it there at bedside in the ED. I usually do I used to do a digital block while knocking out the digital nerve on both the radial and ulnar side of the digit. So it'd be 2 sticks, but when I rotated with the hand team here in New Orleans, the way they do the digital blocks, they pretty much palpate the metacarpal head of the digit. And usually if you stick there and you inflate there or introduce lidocaine or numbing medicine at that point, it knocks out the entire digit because it anesthetize the nerve before it splits. So that's 1 stick versus 2 sticks, what I used to do.
I'm sorry.
So that's kind of one.
Where was that at? You said it was the...
Right. So say if I have to numb, someone has abscess on the index finger. You palpate the metacarpal head of the index finger. Okay. The digital nerve comes up, and then, it splits on the radial side and on the side, right? But if you knock it out right there before it splits, which is right about the metacarpal head, then that's 1 stick versus 2 sticks to knock it out. And so they would get some numbness on that entire finger, but probably like the radial side of the middle finger as well a little bit, because it splits and goes that way. And so I just palpate the radial head, and then I take 20 cc's and I fill it up in that spot. And that usually knocks out the entire digit, both dorsal and volar as well.
And are you putting the I guess lidocaine, are you doing that volarly or?
Sorry, it's going to be volar. Yes.
Okay. Yeah. Okay. Yep. Okay. So, I've done that before too. Yeah. Okay. I see what you're saying.
So that's one thing. They hate it. I mean, they scream this and stuff, but it's better than filling it up or doing 2 sticks. Again, you try to minimize the amount of trauma for someone. And for amputations, unfortunately, I mean, you have to do them in the ED. Some people have injuries and accidents, and New Orleans is an interesting place. You get people who stick their hand and are running a lawnmower to try to remove some of the grass that's stuck in there. And you got fireworks and people blow their hands off and fingers off and those things, and car accidents and people, butchers who cut the thing off. We just run your back to, say it was at the tip of, we just run your back to you can close it. I mean, that's the best thing I can recommend. It's like, you need soft tissue coverage to close the distal aspect of the amputation site. So, sometimes you have to take it back as much as you can to make sure that you have enough tissue to get it close.
Yeah, those finger amputations, man, they can really put a damper on your day when you have a couple consults and then someone tell you finger amp in there.
I'm telling you, you get the, I'm bad that I patrol the ED board, before I'm on call, before I go to lay my head down and get some sleep for a little bit. I see the hand consult and I look at the x-rays for anything. I'm telling you, you see one that's, you see obvious deformity and soft tissue damage and debris everywhere, you're going to be in the hospital for a couple hours. And for the significant ones, we try to take them back to the operating room, obviously. And especially if you have like a hand staff that's on. But usually a lot of these things can be done in the ED.
Absolutely. But luckily, our fellows, we have some hand fellows, and they are very, they take a lot more, they try to do a lot of revascularization, I think a lot more than some other people would, but it takes a little work off of me. And if you just have to kind of lay out all the details to the patient and let them know that sometimes it's a long process. But if sometimes they want to save their finger, and sometimes they're like, hey, man, get this thing off of me. I don't want to deal with all that. And, just give them an option. We take it out to the OR.
Yeah, that's absolutely correct. It's about the clientele too. I mean, if you have a unfortunate young female who's in a car accident and got pretty nails, I mean, they're gonna want to save it more so than a carpenter who was working out at his wood shop and took off the tip of his finger. You're like, yeah, just cut it back, and they go back working within a week. So,
absolutely. And this was a good talk. I'm really enjoying this one. I think I'm liking how much time we're spending on everything because it's actually something. It's very helpful. I think we're going to break this up into two parts so that our listeners can kind of just listen into upper extremity, and we'll have a separate episode for lower extremity. We always give our speakers a way to either give their social handles or their email address, something that our listeners can reach back to you if you would like. Is there any, social media, something like that you would like to put on air for our listeners?
Oh, sure. Yes. My Instagram, trust me, I'm brand new. I'm a rookie with it. So I'm just now starting to explore the social media aspect of it is DW Johnson 100. So you can shoot me a message on there or email address is easy. Is Dr. Donovan Johnson, MD @gmail.com. Someone recommended me to have a basic email address like that just in case for anybody want to reach out to me. So those two ways is probably the quickest and easiest way. I usually respond within a half hour or so from those two.
Guys, thank you so much for listening to that episode of Nailed It Orthopedic Podcast with one of my chief residents, Dr. Johnson, otherwise known as DJ. Now, again, guys, if you are a lower level resident, first year, second year, or even if you're a fourth year student just matched, this episode was, it had a lot of good tips and tricks. I hope you guys took some notes. I was actually just re-listening to this, editing it, and I was like, man, this actually had a lot of good information here. So, stay tuned for part 2 where we talk about some lower extremity tips, which is also a really great episode. Guys, follow us, subscribe, follow us on Instagram at Nailed It Ortho. Of course, go and please, leave us 5-star ratings if that's what you feel like this deserves. Guys, until next time.